Hello everyone, my name is Dr. Ambud Misra, and in this video we are going to discuss about glycogen storage disorders. But before that, let's discuss some basics. So as we know already that glycogen is the branched polymer of alpha D glucose, and the linear linkage is due to alpha 1,4 glycosidic bond, and the branches, the bond from where the branch originates is your alpha 1,6 glycosidic bond. So how you can remember this? So you know the last letter of linear is R and last letter of 4 is also R. So in linear linkage, the bond that is responsible is your alpha 1,4 glycosidic bond. So you can remember from R, from the last letter of 4, and the last letter of linear is also R. So in this diagram you can see this is your primer, that is known as glycogenin, which is your primer, and these all are alpha 1,4 glycosidic bonds, and this right here from where the branch originates is your alpha 1,6 glycosidic bond. Now let's discuss about the process of glycogenesis. You know, glycogenesis occurs in order to store glucose in the form of glycogen, and which is found as in the form of cytoplasmic granules. So where does the process of glycogenesis occurs? So glycogenesis, so like in which state it occurs? So it occurs in fed state. In fed state, that is your 4 to 6 hours postprandial, means after having your food, and Ig ratio, that is your insulin glucagon ratio, should be high in order to facilitate the process of glycogenesis. Means there will be more insulin. And which organelle is responsible for the process of glycogenesis? It is your cytoplasm. So what is the rate limiting enzyme of your glycogenesis? That is your glycogen synthase. Glycogen synthase is the rate limiting enzyme in the process of glycogenesis. So glycogen synthase means it is going to do the synthesis of glycogen. So glycogen synthase is the rate limiting enzyme in the process of glycogenesis, and the active glucose donor in this case is your UDP. It is your UDP glucose, where the glucose is bind to the tyrosine residue of UDP. And what is the primer? As we already discussed, this is your primer to which the chain of glucose is attached. So primer is your glycogenin. So in order to form glycogen, we need to attach the units of glucose to one after another, and for this we need an enzyme, that is your branching enzyme, and in this case your branching enzyme is your alpha 1,4,1,6 glucan transferase. Alpha 1,4,1,6 glucan transferase is your branching enzyme. Now what is glycogenolysis? It is, you know, as the name suggests, it is the breakdown of the glycogen to form, you know, glucose in the case of your liver, and in case of muscle, it doesn't form, the end product is not the glucose. Instead, it going to form lactic acid by entering the process of glycolysis. So where does it occurs? Like, when does it occurs? It occurs in your fasting state, or you can say post absorptive state, that is your 4 to 16 hours after having food. So this occurs in fasting state, and the source of blood glucose is your liver or hepatic glycogenolysis, and not your muscle glycogenolysis. Why is it so? That we will see further in the video. And insulin glucagon ratio should be decreased, should be less. That is to say, because the glucagon needs to be high in order to carry out the process of glycogenolysis. What is the site? So the site is your liver and your skeletal muscles. And the organelle, again, the majority of the glycogenolysis, it occurs inside the cytoplasm, and a fraction of it also occurs inside the lysosome, that is roughly around 1 to 2%. And smooth endoplasmic reticulum, it plays an important role in the process of glycogenolysis. And what is the rate limiting enzyme in the process of glycogenolysis? That is your glycogen phosphorylase. So in case of your glycogenesis, the rate limiting enzyme is your glycogen synthase, and in case of glycogenolysis, the rate limiting enzyme is your glycogen phosphorylase. And what is the debranching enzyme? In order to break down glycogen, we need to break down the bond between the glucose, between two adjacent glucose molecules. So that is going to happen with the help of debranching enzyme, and which is your alpha 1,4,1,4 glucan transferase and your alpha 1,6 glucosidase. These two enzymes are responsible for breaking down the bond between the two glucose primers. Okay, so let's dive into the GST proper. So GST is a glycogen storage disorder where there is defective metabolism of the glycogen, and it is primarily of two types, that is your liver GST and muscle GST. In liver GST, the glycogen metabolism is defective inside the liver, and in muscle GST, it is defective inside your skeletal muscles. So what is the primary feature by which you can say that this is a liver GST? So the main feature of liver GST is your fasting hypoglycemia. You are going to see fasting hypoglycemia in case of liver GSTs, and in case of muscle GSTs, it is your exercise intolerance. You are going to see exercise intolerance in case of muscle GSTs. So you are not going to see like exercise intolerance in case of liver GSTs, and you are not going to see hypoglycemia in case of muscle GSTs. So there will be no exercise intolerance, and there will be normoglycemia in case of muscle GST. Why so? Because in liver, the liver is responsible for blood glucose level. So whenever the glycogenolysis is defective in liver, it is not the glucose is not going to get produced, so there will be fasting hypoglycemia. But muscle, skeletal muscle is not responsible for, it doesn't contribute to the blood glucose level. So when there is defective glycogen metabolism in muscles, it is going to cause exercise intolerance, because when during the exercise, muscle needs energy from the breakdown of glycogen when it enters the process of glycolysis, further forming lactic acid, and thereby it gets 3 ATPs. So when it is defective in case of muscle, the patient is going to face exercise intolerance, but there will be normoglycemia as the glycogenolysis in liver is normal. So this is the main reason that we see exercise intolerance in case of muscle GST and not in case of liver GST. Now, what are the types of liver GSTs? So the first one is your von Guericke's disease. And what is the enzyme defected in this case? Your enzyme defected is your glucose 6 phosphatase, which carries out this reaction. It converts glucose 6 phosphate to glucose. And this process occurs only inside the muscles. So how can you remember that, first one is your von Guericke? There is like really basic mnemonic. So 1 and von, it sounds similar. So your von Guericke is your 1, means your first GST. And 1B, it is also known as von Guericke's. It is a type of it is also known as von Guericke's, and it is really rare. And in this case, what is defective is your glucose 6 phosphate transporter, which transports glycogen from cytoplasm into the smooth endoplasmic reticulum. Why it does so? It is done because the enzyme that is your glucose 6 phosphatase is present inside the smooth endoplasmic reticulum. So in order to facilitate the process of glycogenolysis, the glycogen must need to go from cytoplasm to your smooth endoplasmic reticulum, and that is done by glucose 6 phosphate transporter. So when this is defective, you will see type 1B. It is not really important. The next liver GST is your third type, that is your Cories. So C is your third letter. So that's how you can remember. The third one is your Cories. And the enzyme that is defective in case of Cories is your debranching enzyme. Your debranching enzyme. Okay. Cories disease is also known as dextrinosis. So dextrin is also a polymer of glucose, and when the debranching enzyme is defective, it cannot break properly the molecule of glycogen. So it end up forming dextrin, and which is deposited inside the liver. So dextrin is, you can say, is an abnormal form of glycogen. And similarly, amylopectin is also an abnormal form of glycogen, which is your fourth type of GST, liver GST, is your Anderson's disease. And the enzyme defective here is your branching enzyme. Is your branching enzyme. So there is one mnemonic, that is your C, D and A, B. So Anderson, the enzyme defective is branching enzyme, and Cories is the enzyme defective is your debranching enzyme, and the third letter is your C. So the third GST is your Curie's disease, and you can remember like CD and AB, which is third and fourth. Now the sixth type of GST is your Hirsch disease, and in this case, the enzyme defected is your hepatic glycogen phosphorylase. So glycogen phosphorylase is defective as it is an it is the liver GST. So it is your hepatic glycogen phosphorylase, or you can also remember H from H. But if you know like your 1, 3, 4 and 6, these are your liver GSTs. So 6, the enzyme defective is your glycogen phosphorylase, and as it is a liver GST, so it is your hepatic glycogen phosphorylase. Now moving on to types of muscle GST. So there are three like that we need to remember: the second, the fifth, and the seventh. So 2 plus 5 is equal to 7. That way you can remember it. So what enzyme is defective in case of Pompe's disease? That is your alpha glucosidase, or you can say acid maltase. The fifth one is your McArdle's, and in case of McArdle's, the enzyme defective is your muscle glycogen phosphorylase. See, in case of Hirsch disease, that is your sixth GST. Your enzyme defective is hepatic glycogen phosphorylase, as it is liver GST. And in case of McArdle's, your enzyme defective is your muscle glycogen phosphorylase. So fifth one is your muscle GST, and one more way you can remember it is by M and M. So M goes with M, McArdle goes with muscle glycogen phosphorylase, and Hirsch goes with hepatic glycogen phosphorylase. And the seventh one is your Taru's disease, and the enzyme defective is your muscle and erythrocyte phosphofructokinase type 1. Now one more important thing that you should remember is the glucose is an allosteric inhibitor of the process of glycogenolysis in case of liver, but not in case of muscle. Why is it not an allosteric inhibitor in case of your muscle glycogenolysis? It is because glucose is the end product of glycogenolysis in case of liver, but this is not true in case of your skeletal muscles, because your skeletal muscles, they lack this enzyme known as glucose 6 phosphatase. Glucose 6 phosphatase is present inside the smooth endoplasmic reticulum, and this enzyme is absent in case of skeletal muscle. So what happens when the glycogenolysis occurs in skeletal muscles? The last step, when the glycogen, the glucose primers that are attached to the glycogen, which when they are broken down, they forms glucose 1 phosphate, then glucose 6 phosphate, and ultimately it is going to form glucose, which is the last step, and that is done by the enzyme glucose 6 phosphatase. And this process doesn't occur in case of your skeletal muscle, because skeletal muscles lacks this enzyme. So what happens, this glucose 6 phosphate then enters glycolysis, and further it forms lactic acid, and thereby releasing 3 ATPs, which is utilized when the person is exercising. So Glucose is the end product of glycogenolysis in case of liver, but not in case of your skeletal muscle. In case of muscles, you know why? Because muscle lacks this enzyme glucose 6 phosphatase. So in liver, glucose 6 phosphatase is going to form glucose 6 phosphate is going to form glucose with the help of this enzyme, but this doesn't occur in case of muscle. So glucose 6 phosphate is going to enter the process of glycolysis, which is further going to form lactic acid and liberate 3 ATPs, which will be utilized when the body is exercising. So now dive into the disease proper. The first one is your von Gierke's. We will be discussing only really important points and the differentiating features that we must remember in order to differentiate these types. So von Gierke's. So all the liver GSTs you are going to see fasting hypoglycemia or hypoglycemia. So this is not really important. So in case of 1, 1st, 3rd, 4th and 6th, these are liver GSTs and you are going to see hypoglycemia. So we already know this, but what are the defining clinical features? The first one that you can remember is your hyperuricemia. Hyperuricemia. You will also see ketosis. You will also see hyperlipidemia. And the patient is going to present as it is that it will appear like the face is going to appear like a doll. So it will be like doll-like faces. The facial features will be doll-like, and in this case you will see chubby cheeks, but thin extremities. And the one more feature, that is your protruding abdomen, which is because of hepatomegaly plus renomegaly. Hepatomegaly and renomegaly, not splenomegaly. Renomegaly occurs because there is hyperlipidemia, which causes excess fat deposition inside the kidneys, and hepatomegaly it's because there is accumulation of the process of glycogenolysis is defective, so there will be accumulation of the defective metabolites of glycogen, which will result in hepatomegaly. So the defining feature will be your hyperuricemia and your doll-like feces. These two you must need to remember, because these will differentiate it from all the other types. So hyperuricemia and doll-like feces is the defining feature of your von Gierke's, and whenever you see in the question these two features, you are going to mark straight away your von Gierke's. That is your first. Von means one. The third type is your Cory's, and what are the defining features? And one more thing, like in type 1b, you will see all these features of von Gierke's, the type 1a, plus you will also see neutropenia, and which will further cause recurrent infections. That is not really important, so you don't have to remember that. Now the type 3 is your Cory's, and what are the defining features is there is abnormal glycogen deposition in liver. The glycogen that is deposited inside the liver is abnormal form, and you will see, so you are obviously you are going to see fasting hypoglycemia, as it is the type of liver GST. You are going to see protruding abdomen, So you are also seeing protruding abdomen in case of von Ger case. So how it is different from von Ger case? It is different because you will see hepatosplenomegaly. Hepatosplenomegaly. So whenever the question says the patient has fasting hypoglycemia along with hepatosplenomegaly, then you are going to think about Cory's disease, that is your type 3, which is your liver GST. What else you need to remember is your micronodular liver cirrhosis. Micronodular liver cirrhosis. Okay, so now let's see, the next type is your Anderson's. So what are all you are going to see in the case of Anderson's? So Anderson's, here also you will see the deposition of abnormal glycogen in liver. Abnormal glycogen is going to get deposited inside the liver in case of Anderson's. Plus you are going to see ketosis. Where else you saw ketosis? You saw in case of von Ger case, and you are also going to see in case of Anderson's, and you are also going to see micronodular liver cirrhosis. So if in question it's given the ketosis along with cirrhosis, this is your Anderson's. But if the ketosis is is given along with your the chubby cheeks, the thin extremities, and hyperuricemia, this is going to be your von Ger case. So this about this you need to be careful, that ketosis and cirrhosis is the defining feature of Anderson. In Cory's, you are going to see hepatosplenomegaly and cirrhosis. Hepatosplenomegaly and cirrhosis. And in case of von Ger case, hyperuricemia and doll-like facies. So if you remember only two of all these features, you can easily mark eliminate other types, and you can mark the correct answer. So these two in case of von Ger case, hepatosplenomegaly, cirrhosis in case of Cory's, and ketosis and cirrhosis in case of Anderson's. And obviously you are going to see hypoglycemia in all these cases. In hers, it is not really important, and you are not going to see that evident hypoglycemia. So there will be hypoglycemia, but that won't be that evident. So in this case, there will be mild hypoglycemia. Why there will be mild hypoglycemia? Because in this case the process of gluconeogenesis is intact. Because why you are going to see mild hypoglycemia? Because here gluconeogenesis is intact. Why in rest of these three, in von Ger case, Cory's, and Anderson's, the process of gluconeogenesis is not intact, because in these three, the oxaloacetate, that it is already depleted, because so it is not available for the process of gluconeogenesis. But this is not in case of Hirsch disease. So there will be mild hypoglycemia because gluconeogenesis is intact. You just need to remember this. That's it. Now further going into the muscle GSTs, the second one, that is your Pompey's disease. And what are all the defining features? So it is also a lysosome storage disorder, but in this case, that what you need to remember, that the normal glycogen is deposited inside the skeletal muscles, inside the lysosomes of the skeletal muscles. So it is also an lysosome storage disorder, and the form of glucose, that glycogen that is going to deposited is normal form. So normal glycogen is going to get deposited, and it is also a form of a lysosome storage disorder. And what are clinical features you will see? There will be feeding difficulties, feeding difficulty. The baby will be hypotonic, that is floppy infant. Baby will be hypotonic, that is floppy infant. And the next is in case of Pompe's, it is really, the most defining feature of Pompe's is your hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, which will cause, cardiomegaly, and the baby is not going to survive after 2 years of age. It's very hard for baby to survive after 2 years of age. So death after 2 years of age in case of Pompe's. So hypertrophic cardiomyopathy is really the most defining feature of Pompe's disease. And in this case, whenever you see, hypertrophic cardiomyopathy or cardiomegaly, or baby is hypotonic, or baby is having feeding difficulty, straight away you are going to mark Pompe's. That is your second GST, and it is a form of muscle GST. The next one is your, so how, how you can remember, Pompe's and pump. So heart is a pump, it pumps blood. So Pompe's pump means it is something is related to heart. So Pompe's you can relate from pump, and pump is your heart. So there is something wrong with your heart, that is your hypertrophic cardiomyopathy, which will cause cardiomegaly. So I will write here Pompe, pump, hypertrophic, heart, that is hypertrophic cardiomyopathy. That's how you can remember it. The next one is your fifth type, that is your myocardial. And in myocardial, what are all the defining features? You are going to see exercise intolerance, and you are going to see second wind phenomena. What is second wind phenomena? This is really the defining feature of myocardials. So you are going to see exercise intolerance along with second wind phenomena. It is like whenever the patient starts doing exercise, the patient is going to have pain inside the muscles, and as soon after the patient stops doing exercise, the pain goes away, and again when the patient is going to start the exercise again, the pain reappears. So this is your second wind phenomena. So that is pain during exercise which subsides with rest and reappears with exercise again. Now, what is the next feature that you need to remember in case of myocardial is your rhabdomyolysis. Rhabdomyolysis. So whenever there is rhabdomyolysis, you are going to see myoglobinuria, and because of that myoglobinuria, and because of that you are going to see burgundy color urine. So burgundy color urine, if given along with second wind phenomena, or it says the question says the patient is whenever the patient starts exercise, it has pain, and whenever it stops the exercise, the pain goes away. That is your second wind phenomena. So whenever you see second wind phenomena and burgundy color urine, straight away you are going to mark McArdle's. That is your fifth type of GST, that is your muscle GST. And whenever you see hypertrophic cardiomyopathy, cardiomegaly, something related to heart, and the baby is hypotonic, feeding difficulty, you are straight away going to mark Pompey's. That, so pump and Pompey's, that are related. The next one is your Tarois. That is not really important, but still, in case of Tarois, what are clinical features you are going to see is your obviously exercise intolerance. It's obvious. You are also going to see myoglobinuria. So again, you are going to see, burgundy urine. And you are going to see hemolysis, which is important. This is your important feature. Okay, so why you are not going to see exercise intolerance in case of Pompey's? Because the patients, which are affected with Pompey's, they are not going to survive very long, like till they are able to do exercise and complain that they are having pain, or they are like not able to do exercise. There is exercise intolerance, so like the baby is not going to do exercise, right? So you are the feature of exercise intolerance is not related to Pompey's, but you need to remember it in case of McArdle's and Tarois. So in case of muscle GST, the Pompey's, pump, heart, hypertrophic cardiomyopathy, cardiomegaly, hypotonia. This is important. In case of McArdle's, you are going to see second wind phenomena and burgundy color urine. Straight away you are going to mark McArdle's. In case of Tarois, if along with exercise intolerance hemolysis is given, you are going to mark Tarois. Okay, so these are all different types of GSTs. Now let's discuss how you can identify and eliminate any type of GST. So if there is fasting hypoglycemia, straight away it is either 1, 3, 4 or 6, and if it is exercise intolerance, it is your 2, 2nd, 5th or 7th. Second, like we will not consider, but still. So means it is your liver GST, that is your 1st, 3rd, 4th and 6th, and it is your muscle GST, that is your 2nd, 5th and 7th. If along with fasting hypoglycemia, the question says there is abnormal form of glycogen is present, see straight away it is either 3rd or 4th. 3rd and 4th. 3rd is your 3rd letter C, Corey's. 4th is your Anderson's. C goes with D, A goes with B. C goes with D, means debranching enzyme is defective in case of Corey's, and after that is your Anderson's. Okay, so there is one cricketer named Corey Anderson. So after Corey there comes Anderson. You can remember by this named Corey Anderson is a cricketer, if you have heard of him. So third one is your Corey's. You can remember by this, like the C is your 3rd letter, and it is also the 3rd type of GST. After that Anderson, because Corey Anderson is next. So C goes with D, that is debranching enzyme is defective in case of Corey's, and Anderson, A goes with B, that is your branching enzyme. So whenever the question says fasting hypoglycemia plus abnormal glycogen present, it is either 3rd or 4th. If along with fasting hypoglycemia the question says abnormal glycogen is absent, it is either your 1st one or your 6th one, the rest of the liver GST, because in 1st and 6th abnormal glycogen is absent. If question says exercise intolerance along with second wind phenomena, you don't have to think about it, straight away you are going to mark your McArdles, that is your fifth type of GST. Okay. If along with exercise intolerance it says no second wind phenomena, then it is your no second wind phenomena. It is your seventh type of GST. Okay, seventh type. And if say it says along exercise intolerance along with hypertrophic cardiomyopathy, you already know, like, this is the defining feature of Pompe's, that is your second type of GST. So this is going to be your second type. So exercise intolerance, second wind phenomena, fifth. Exercise intolerance, no second wind phenomena, it is your seventh type. And if it says hypertrophic cardiomyopathy, you are going to mark the second one. Like, you don't need exercise intolerance here, but whenever you see HCM, hypertrophic cardiomyopathy, you are going to mark the second one. So if you see hypoglycemia plus ketosis, it is either first or third. It is either first or third. So if you will read the question, if you see only ketosis, not so many, not other features, then it is going to be the third one. Because in case of von Gierke's, there must be some other features, like hyperuricemia, like doll-like faces, the chubby cheeks, or hyperlipidemia. You will also see these features. So like you can easily eliminate the other one, and if it's not given, it's going to third one. And if along with ketosis, you will definitely see the other clinical features. So and also, like, there is one test known as IV glycogen challenge test, which IV glycogen challenge test, which is also going to differentiate easily between the first and third type of GST.